So as I've mentioned, so I'm going to talk now briefly about the shared decision making in the management of patients with multiple long-term conditions. So multiple long-term conditions, but when we say multiple long-term conditions, we mean the coexistence of two or more chronic conditions in a single patient. As we all know, the prevalence of multiple long-term conditions is on the rise, and actually effectively managing patients with multiple long-term conditions is amongst the most significant challenges faced by primary care clinicians, but also clinicians across all specialties today. Patients with multiple long-term conditions have been shown to have a poorer health-related quality of life, poorer functional status, and an increase in healthcare usage across both primary and secondary care settings. And actually, in a primary care context, it's previously shown that 78% of consultations involve patients with multiple long-term conditions. So as we can tell, it's a very significant problem. So why is it so difficult to manage patients with multiple long-term conditions? The guidelines that are set up to advise clinicians in clinical decision-making are often focused on single diseases, and when applied to patients with multiple long-term conditions, can actually lead to contradiction and fragmentation of care. The interplay between these multiple treatment regimens, the various treatment regimens for each of the chronic conditions that the patients suffer with, unsurprisingly leads to an increased risk of polypharmacy, and also an increased treatment burden with multiple appointments and multiple management plans to keep track of in this patient group. And actually, again, the risk of adverse drug events as a result is also increased in this patient group. And these are just amongst the factors that contribute to the increased challenge of clinical decision-making in the management of patients with multiple long-term conditions. So why is shared decision-making important? So involving patients in the clinical decision-making process is long been promoted as integral to providing individualised, patient-centred care, and actually is promoted as a hallmark of good clinical practice. It is also important from an ethical perspective across all healthcare delivery for patients' autonomy to be respected and for patients to be informed of the benefits and risks of the decisions to be made relating to their healthcare. This is especially important in the context of multiple long-term conditions, where actually the benefits and the risks of treatment regimens may be less clear-cut and more complicated by the interplay between different regimens for the different conditions that the patient may suffer from. And so it's previously been suggested that promoting individualised patient-centred care in which each patient's case is considered on a holistic and personal basis is key to tackling the complexity of patients with multiple long-term conditions. And actually, as part of this process, eliciting the patient's health outcome priorities and preferences, so what's important to the patient, is key, as it can help to provide clarity for both the clinician and also for the patient in navigating through the shared decision-making process, potentially also reduce treatment burden by focusing on what's actually important to the patient. But what makes this process difficult, or what have been the challenges? It's previously been shown that doctors actually find it difficult sometimes to incorporate the process of eliciting patients' priorities of what's important to the patients in front of them into their consultations, and actually sometimes might omit doing so altogether. The time constraints of general practice appointments may be one factor that's responsible for this. Patients may also actually find it difficult to express their feelings and their thoughts and what's important to them in the constraints of a single consultation, and may actually need time to consider these things before and after their appointments. Doctors may also may be at risk of making a preference misdiagnosis, as it were, in which they may make an incorrect assumption regarding what's important and the priorities and preferences of their patients. And actually previously in single disease contexts, for example, it's been shown that doctors significantly overestimated the extent to which patients suffering with breast cancer prioritise retaining their breast as part of their management. And then another study found that doctors significantly overestimated the extent to which older patients prioritise continuation of life in the context of advanced dementia, resulting in severe cognitive decline. And in the context of multiple long-term conditions, previous research has actually found a mostly low level of agreement between the priorities of patients with multiple long-term conditions and of clinicians in the context of multiple long-term conditions. It was previously found that The mechanisms of prioritisation also differed for patients and clinicians, in that for patients, these were mainly driven by their illness experiences, whereas for clinicians, the focus was more on longer term risks. And also actually the importance of eliciting and considering both the short-term and long-term priorities of patients with multiple long-term conditions, and also for these to be reviewed continually, particularly when factors such as illness exacerbations, changes to disease courses, changes to treatment regimens, or other wider socially contextualized changes occur was demonstrated. And the need for the development of a standardized and validated tool that is acceptable to both patients and clinicians, and that can be used in consultations to ascertain the priorities of patients with multiple long-term conditions, and facilitate shared decision-making and thus promote patient-centeredness was highlighted. And so it was this that actually led to the work that we're currently doing to facilitate priority setting and shared decision making in the management of multiple patients with multiple long-term conditions. So here at the Leicester Diabetes Centre, we're currently running a questionnaire study to test the feasibility and applicability of the outcome prioritisation tool, which is a pre-validated tool that was actually initially developed in the early 2000s in America to elicit the health outcome priorities of patients with multiple long-term conditions and in a primary care setting here in the UK. So the primary objective of this study was to investigate the patient-reported relevance, ease of use, and patient-perceived usefulness of the outcome prioritisation tool in ascertaining the health outcome priorities of patients with multiple long-term conditions in a multi-age and multi-ethnic setting. By multi-age, we mean that this tool was actually previously only used in patients aged over 65, so in older patients with multiple long-term conditions. But as we now know that middle-aged patients with multiple long-term conditions, the prevalence is growing and is increasingly becoming a significant problem. We sought to sort of to widen the age range that this tool can be applied to, and in the multi-ethnic setting that we have here in the East Midlands. And the secondary objective was to describe the health outcome priorities of patients by clusters of multiple long-term conditions and by age categories, and also by different ethnic groups, to consider how priorities may differ by these factors. And actually, in light of the COVID-19 pandemic, we then added an additional step to separate health outcome prioritisation by priorities before the onset of the outbreak and of current health outcome priorities. So in addition to the previously defined aims, the aim of this additional step was to evaluate the impact of COVID-19 on health outcome prioritisation in our participant group. So this here is a snapshot of the outcome prioritisation tool. So this is a page from the questionnaire. It's currently being delivered on an online format, but this is one of the pages really. So there's 4 domains: maintaining independence, keeping you alive, reducing pain, reducing other symptoms. And patients are asked to give a rating from 0 to 100 for each of these domains. And we've given some information as well to guide patients on how to make these choices, and also consider the priorities as trade-offs. So to give different scores to the various domains. So in terms of the progress that we've done so far, so we've recruited over 2,400 participants with multiple long-term conditions from 19 GP practices across East Midlands, so from Leicester City, Leicestershire, Northamptonshire, Nottingham City, Nottinghamshire, Derby City and Derbyshire. And this is just, again, a snapshot of some of the results that were captured through the RedCap software. So as we can see here, it's looking like most patients are agreeing that the outcome prioritisation tool will be useful in communicating their priorities to their doctors. So some encouraging results there so far. And so where do the results of this study lead? The results from this study will actually help us to assess whether the outcome prioritisation tool can be effectively used to ascertain the priorities of both middle-aged and older patients with multiple long-term conditions in primary care consultations in the UK. The results from this study will also make a novel contribution to the existing literature on health outcome priorities of a multi-ethnic population with multiple long-term conditions. And they'll also contribute to the development of an intervention to promote the incorporation of patient priorities and thus facilitate shared decision-making in primary care consultations with patients with multiple long-term conditions. And then they will also improve understanding of the impact of COVID-19 on health outcome prioritisation, which patients with multiple long-term conditions, which hopefully will facilitate clinicians and policymakers on developing guidelines and strategies of delivering patient-centered care for patients with multiple long-term conditions as we move into the recovery phase from the COVID-19 pandemic. Okay, I've just got some references here. I'm just going to stop sharing my screen now. So yeah, thanks very much everybody for listening, and we've got some time now for any questions or any comments or any thoughts that anyone's had, so feel free to share either by posting them in chat or by raising your hand, but please bear with us with the raised hand function as there's a bit of a delay in that coming up on my Zoom. Okay, thank you. Oh, Shukrat, I think you had your hand raised there.
Sorry. Yes. Hi, thank you for the presentation, Harini. I was just curious, there was a page on the questionnaire that you showed where you had the different domains, and you mentioned trade-offs.
Yeah.
I was just imagining, does that mean the idea is the patient can't get 100% for each of the domains, so they have to decide what they'll have less of and what they'll have more of? Is that the way it works?
Yeah, absolutely. So basically, what I'll do is I'll share the screen again and bring that page up so that we can all see. Sorry, just bear with me a moment. Okay, so yeah, so absolutely. So there are 4 domains as we described, and yeah, so the trade-off principle basically was to encourage patients to, rather than potentially think that actually all of those elements are important, because of course they're all very important health outcomes, but to consider that there may be a situation where they may have to kind of make a choice on what is most important to them to guide their treatment regimens, where it might not be possible for all outcomes to be achieved, but it may be that they have to consider things as trade-offs, or as what's relatively most important to them compared to the other priorities. So it's sort of this concept of a hierarchy of ranking, as it were, across the 4 priorities. Does that answer your question? I think you're still muted, Shukrat. Sorry.
Yeah, I was just asking, could we get to see the slides afterward? I would just like to have a closer look.
So the one, can you see this one here? So the one afterwards, did you say?
This one, and I don't
know. The one afterwards.
No, could we get the whole presentation slides, or?
Yeah. So you want that emailed round? Did you say afterwards?
Yes. Yes.
Yeah. Okay. Yeah. Sure. Yeah. No, we can send those around. No problem.
Thank
but
you.
So there was this slide. Did you say, was there another slide you wanted to look at?
There was one that caught my eye later on, but
okay.
That's why I said if I had the whole batch, I'll just.
Yeah, sure. Yeah, no problem. No, that's absolutely fine. So what we'll do is, we'll email the presentation round as well, so you can have a closer look. Okay, thank you. So I'll stop that there. Thank you. And then I've got another question here from Mark Gilbert, who says, what if patients don't feel that their priorities are reflected in the 4 domains? Yeah, absolutely. And this was actually something that came out through the PPIE work that we did before as part of the design of the study. I think this was the difficulty really with it being a pre-validated tool that we were using, that we were unable to kind of add in domains or kind of make changes to the tool itself. But actually also I suppose the idea for the tool itself is to be a conversation starter, or kind of a tool, like something to facilitate patients to consider what's important to them, and to kind of initiate those thoughts and initiate those conversations, rather than being something that could be considered to be an absolute capture of what's important to the patient. So perhaps in the future, as when we develop we incorporate the tool into an intervention to facilitate shared decision making, and that would be important to stress that it's it's not that patients are making a choice on what will happen to them. It's more that it's something to encourage them to consider what might be important to them, and of course that there may be things that aren't captured in those domains. I hope that answers your question there.
It does, yeah, thank you.
Thank you. Okay. Are there any other thoughts at all, or anything else that anyone wanted to raise? Okay, thanks very much, everybody. Thank you for listening. So now we'll move on to our next speaker. So next we have Dr. Courtney Lightfoot speaking about self-management and multiple long-term conditions in chronic kidney disease. So Courtney is a mixed methods researcher working with the Leicester Kidney Lifestyle team here at the University of Leicester. She has an interest in self-management, health and lifestyle behaviours, and experiences of living with kidney disease. Her work focuses on helping people with kidney disease to live well by empowering them to take a more active role in their health and healthcare. Thank you very much, Courtney. I'll mute now and hand over to you.
Thanks, Harini. I'll just share my screen. Can you see my slides?
Yes.
Perfect.
Yeah.
So as Harini said, I'm going to be talking about self-management and multimorbidity in chronic kidney disease. So I'm just going to give you a little bit of an overview about what I'm going to talk about today. So I'm going to define what chronic kidney disease, self-management and patient activation are. I'm going to talk a little bit about the importance of patient activation and self-management in people with kidney disease, and then some of the challenges that we experience with those. And then I'm going to talk a little bit about some of the work that we've been doing in the Leicester Kidney Lifestyle team. So we've developed an online self-management programme for people with kidney disease called My Kidneys and Me. And I'm going to talk a little bit about the development, evaluation and implementation of this programme. And then I'm going to finish on talking about multimorbidity management in kidney disease. Chronic kidney disease is a long-term condition that's characterised by decreased kidney function or markers of kidney damage that are present for at least 3 months. It affects around 1 in 10 people globally. And it's a progressive disease that's associated with an increased risk of morbidity and mortality. And those with progressive disease can end up at end-stage kidney disease where dialysis or transplantation may be needed. And many individuals with kidney disease have what we call non-dialysis kidney disease, and they are diagnosed and managed predominantly in primary care, which means that they often receive infrequent or no input from kidney specialists in secondary care. Self-management is an essential component in chronic disease management, which enables empowerment of patients to take an active role in their health. It involves a complex set of processes and tasks that utilise an individual's knowledge, skills and confidence to manage their disease, to being able to have an ability to identify and access appropriate resources and support, and also learning to live and cope with the condition, including the impact that this has on the individual's life and also the emotional consequences that are associated with the condition. And supported self-management is a component of the NHS's long-term plan's commitment to personalised care. So as I've already mentioned about the tasks and processes, for self-management to be effective, there are 3 core tasks. This involves the medical management, the role or behavioural management, and the emotional management. And these 3 core tasks are underpinned by 5 key processes that involve decision-making, utilising resources, forming partnerships with healthcare professionals, problem-solving, and taking action. And self-efficacy is required to engage and execute these tasks and processes. And patient activation is a dynamic behavioural concept that describes the degree to which individuals understand their role in their healthcare and how confident they feel in performing that role. It's defined as the knowledge, skills and confidence that an individual has in managing their own health and healthcare. The most commonly and widely accepted method to assess patient activation is the patient activation measure. And this categorises patients into one of 4 levels. So level 1 is the lowest level of activation, and this is where individuals are passive in their healthcare and are often disengaged and overwhelmed. And level 4 is the highest level of patient activation, and this is where individuals take an active role in their health and they're able to maintain health promoting behaviours. So if we look at patient activation in chronic kidney disease, and this is from one of our studies, we looked at patient activation levels across the CKD spectrum in 1,000 participants. And like many others, we found that a quarter of individuals with kidney disease are in the lowest activation level, so level 1, and that less than 20% are in the highest activation level. And this is consistent across the kidney disease spectrum. And I guess quite worryingly is that people with kidney disease have lower activation levels when compared to individuals with other chronic diseases, such as diabetes and multiple sclerosis. And low patient activation in kidney disease is associated with lower kidney function, diabetes, poor cardiovascular fitness, increased cardiovascular risk factors, and increased comorbidities. And higher patient activation is associated with medication adherence, good quality of life, and fewer symptoms. So why is patient activation important, and what's it got to do with self-management? So patient activation is the first step in engaging with self-management, and having the knowledge about a long-term condition and its treatment is an important component of both patient activation and self-management. And having the necessary skills and knowledge of one's own condition will result in better levels of activation. And increased levels of activation are followed by improvements in self-management behaviours. However, differing levels of self-management can be influenced by different levels of activation, and high levels of treatment burden, disease burden, and symptom burden can heavily influence and adversely affect levels of activation in individuals. And activation levels have been shown to correlate with disease-specific behaviours. So individuals with high levels of activation who have diabetes are much better at reading food labels and reading about potential side effects of newly prescribed medication. So why is self-management and patient activation important for people with kidney disease? There's a very fine balance between managing the medical, emotional, and psychosocial consequences of living with kidney disease, alongside any additional comorbidities that an individual may have with their day-to-day responsibilities. And self-management and patient activation are important for slowing kidney disease progression, reducing the cardiovascular disease risk, also other general health risk factors, also reducing the number and severity of symptoms and comorbidities, and improving quality of life. And I guess one of the most important things is that self-management has been identified as a top priority by individuals with kidney disease, their carers and relatives, healthcare professionals, and policymakers. So what are the challenges to self-management in kidney disease? Well, there are significant deficiencies in kidney disease awareness and knowledge that have been identified. So some individuals are not aware of their diagnosis or lack understanding of what it actually means and how the effect of poor risk factor control may have on their health. There are also infrequent and limited discussions about kidney disease and how to self-manage the condition between healthcare professionals and patients, particularly in primary care settings. And there is limited support and education that is available face-to-face about self-management of kidney disease. And digital health interventions are being increasingly used to provide a novel approach to improving knowledge and self-management behaviours, and this is becoming particularly pertinent since the post-COVID era. So there's been numerous reviews about self-management interventions in people with kidney disease, and these have shown that there's been improvements in self-care activities. However, these are variable in their effectiveness for managing and preventing the progression of kidney disease. And this could be assumed because of the wide variations that are available in the intervention content, delivery, and components, and also between the outcomes assessed and the results obtained between the studies, which makes the comparison of finding across the studies very difficult. And whilst theory-driven interventions are becoming increasingly important, those that have previously been developed are largely atheoretical. They also fail to apply behaviour change theory, and only around 20% actually use a theory or framework in the development. They also lack patient engagement in the intervention design, so less than 1% are co-developed with patients and their relatives. And they also lack meaning information relating to patient perspective, which is obviously important. So I'm going to talk a little bit about some of the work that we've been doing in the Leicester Kidney Lifestyle team, particularly in the co-development, evaluation and implementation of our online self-management programme for people living with kidney disease. So the programme's called My Kidneys and Me. It's a theory and evidence-based digital self-management programme, which is structured for 10 weeks, and it's been designed for people with non-dialysis kidney disease. It's been designed and co-developed by kidney researchers, kidney clinicians, the My Desmond team and impact team from the Leicester Diabetes Centre, and also PPI members. This has been a group of patients and their relatives who've been involved in every step of the development of the programme. And the development process was conducted in 2 sequential phases. The first phase involved the development of the resource using the intervention mapping framework. And then the second phase involved the adoption and adaptation of the existing My Desmond platform to suit the needs and priorities of My Kidneys and Me. So the aim of My Kidneys and Me is to improve and maintain self-management behaviours, particularly improving knowledge, promoting self-care skills, increasing self-efficacy, improving well-being and increasing physical activity. And the key programme goals are to increase patient activation, reduce health risks, manage symptoms and increase physical function. So this is just a little bit of a snapshot of what My Kidneys and Me looks like. And on the programme we have educational sessions that help individuals learn about the symptoms that are associated with kidney disease, why it's important to manage them. And then there's how-to sessions which provide strategies to help them put their learning into practice. So for example, we have a session on how to manage symptoms. So this includes about how to recognise symptoms, how to monitor symptoms, and also how they can improve their symptoms. And there are also tracking features available in the programme so that they can self-monitor. So for example, we have symptom trackers where individuals can input their symptoms that they experience and they can self-monitor them over time. So My Kidneys and Me is currently being evaluated in a clinical trial, and this clinical trial is called SMILE-K. It's a longitudinal randomised control trial with a nested pilot study. And the aims of SMILE-K are to assess the effect of My Kidneys and Me on patient activation levels and subsequent self-management behaviours. And secondary aims include assessing the feasibility of using such an intervention in this population, and also to explore patient experiences of the programme itself. And the study period is for 20 weeks, and outcomes are assessed using online surveys at baseline, 10 weeks and 20 weeks. Our target sample is 432, and so far we've recruited up 65% of our target sample size. So alongside evaluating My Kidneys and Me, we're also looking to implement My Kidneys and Me. So we've got an implementation trial that we're trying to develop at the moment. And the aim of this is to evaluate the adoption of, use of and engagement with My Kidneys and Me. So we're just trying to identify the implementation strategies and outcomes, and these are going to be based on what we find from the Delphi survey and the scoping interviews with stakeholders, which I'm just going to discuss over the next few slides. And then we're going to conduct a process evaluation where we're going to examine the implementation of My Kidneys and Me, the contextual factors, and also potential mechanisms of action. This is very preliminary at the moment in terms of the design of this trial, and this will be based on the findings, as I've already mentioned, on the Delphi survey and the interviews, which I'm going to discuss in the next few slides. So priority outcomes in kidney disease are gaining increasing interest, and we have this thing called the SONG initiative, which aims to establish core outcome measures in clinical trials and also other research. And so far, so these are across the CKD spectrum, and there are consistent outcomes that have been identified across this, which include cardiovascular disease, fatigue, mortality, and life participation. There are other outcomes that are CKD stage and disease type specific, but I'm not going to talk about those. So we're looking to identify priority self-management outcomes for kidney disease. And to do this, we're conducting a Delphi survey, which aims to seek consensus and identify outcomes of importance for self-management for people with early stage non-dialysis kidney disease across different stakeholder groups, including patients, their relatives, healthcare professionals, and policymakers. So we're using online surveys to do this, and we're currently conducting round 1 of the Delphi survey. There'll potentially be another 2 to 3 rounds following this. And then in terms of kidney services, so kidney services are currently being redesigned at the moment. So we have this thing called the Renal Services Transformation Programme, and that's redesigning the services based on recommendations from the GIRF report for renal medicine. And the aim of this is to improve the delivery of patient care nationally, to address variations in healthcare and also in inequality, and also to redesign the services to focus on providing specialist advice and to approach an approach to implement more personalised care, and particularly during follow-up. And as a result of this, we're conducting semi-structured interviews, and the aim of these interviews are to explore and understand stakeholder views on kidney education and self-management support. Also to identify what current self-management support is available for people with kidney disease, and how the redesigning of kidney services may be, and where self-management support and interventions may fit in these new designed kidney services. And also to identify how self-management support and interventions such as My Kidneys and Me may be commissioned and embedded within routine practice. So this is currently ongoing. We've recruited about 10 participants so far to the interviews. Next, I'm going to talk a little bit about the importance of multimorbidity management. So these are some studies that we've previously conducted in the team. And the first one is about assessing multimorbidity prevalence and patterns. So this is a graph showing the number of comorbidities that exist for the different stages of kidney disease. So this is across the CKD spectrum. And as you can see, that as kidney disease progresses, the number of comorbidities increases. And worryingly, 96% of individuals were multimorbid. The mean number of comorbidities in addition to kidney disease was 3. And 57% of participants were defined as having complex morbidity. So this is 4 or more long-term conditions. And the presence of 5 or more comorbidities doubled between stages 1 and 2 to stage 3, and then also between stage 3 to stage 4 and 5. And this is just a breakdown of the comorbidities that we looked at, and you can see the prevalence of each of those conditions in the different stages. And then this is a heat map that shows the co-prevalence of the different comorbidities, and as you can see, the highest co-prevalent comorbidities are hypertension and musculoskeletal disorders, and this is consistent across all the stages. And this is another study where we looked at the symptoms in kidney disease. So this is a sample of 2,200 individuals, 850 which didn't have kidney disease. And as you can see, the number of symptoms increase as kidney disease progresses. And also females report an increased number of symptoms to their male counterparts across the CKD spectrum. And these are just some heat maps to show the frequency and the rank of the individual symptoms. And as you can see here, 75%, over 75% reported feeling tired. And this was ranked as the highest number of symptoms across the CKD stages, apart from in people with peritoneal dialysis. So if we look at the top 3 symptoms reported across all participants, over 75% reported feeling tired, and over 50% reported sleep disturbances and pain. And compared to people without kidney disease, the proportion of individuals reporting these symptoms every day was significantly higher for those with stage 3, 4, 5 on hemodialysis and also with a kidney transplant. So to summarise, My Kidneys and Me is an online self-management programme that aims to increase patient activation and promote self-management behaviours in people living with kidney disease. And SMILE-K is a study which is evaluating My Kidneys and Me, and we're hoping that the results will be available towards the end of next year. And we're also collating evidence to support the implementation of My Kidneys and Me into routine care. And multimorbidity is highly prevalent across the CKD spectrum, with different patterns existing at different stages, which adds complexity to the treatment and medication regimes, and also the self-management strategies. And there's also a high symptom burden which is prevalent across the CKD spectrum, with pain and fatigue being frequently reported and warrant the most immediate attention. And there's also a need for a person-centred approach and not necessarily a disease-centred approach. And comorbidities need to be considered to integrate care and provide effective treatment strategies. And these perhaps need to change across the CKD spectrum or as disease progresses. And symptom burden should be assessed to ensure that there's adequate intervention. And a multidisciplinary approach should aim at treating symptoms that are needed to help reduce the number of symptoms and their severity that are experienced by patients. So if anybody's interested, we have a Twitter page which you can follow about the programme and also the studies that we're conducting on My Kidneys and Me. And so I'd just like to thank you for listening, and I'd also like to thank everybody that was involved in this work. Thank you.
Okay, thank you very much. Thank you, Courtney. Thank you for that. So yeah, as before, really, if anyone's got any, so if you'd just like to unshare your screen, Courtney, thank you. So as before, if anyone's got any questions at all, please feel free to post any comments or anything they'd like to raise. Please feel free to raise them in the chat function or raise your hand, please. Okay, I've got a question actually, Courtney. So it was interesting actually to note that there's lower activation levels for patients with chronic kidney disease compared to other chronic conditions. So has there been much work done into why that might be the case?
Not really. So that's something that we're definitely interested in looking at. Yeah. But it potentially could be assumed that because there's less awareness, less knowledge about the condition, and also how to actually self-manage. Obviously the support and education isn't available at the moment if you compare it to something like diabetes, for example. Yeah. So this is perhaps why, although we're not actually entirely sure why, but it's something that we are yet to explore and something that we're keen to do as well.
Yeah, absolutely. Yeah, no, thank you. Yeah, it'd be interesting to find out. So I think Ashcon, you've got your hand up.
Right. I have a very quick question. On one of the slides you had taught me about patient activation, about like the consequences of low and higher patient activation. Could you quickly go back on the slide, because there was one thing I wanted to pick up on, Jessica?
Yes, absolutely. Let me just find it. This one.
Yeah, you said high patient activations associated with transplantation. Isn't it the other way around? Because transplantation is usually one of kind of like the consequences of.
Yeah, so if the person reaches end-stage kidney disease, they need to require some form of kidney replacement therapy, and this is either dialysis or transplantation. So individuals with a higher activation level are much more likely to have a transplant rather than go on to dialysis.
Okay. That makes sense.
Does that make sense?
Yeah, I was just a bit confused, that's all.
That's fine. No, that's fine. Because obviously having a transplant requires a lot of ability to self-manage and to look after your own health. Whereas for dialysis, for example, a lot of that's done in centre, so they'll have nurses and doctors that are helping them or will do the dialysis for them.
Thanks very much.
Okay. Yeah, absolutely. I think that's, as you say as well, it's awareness as well, isn't it? A lot of patients with early CKD might not even be aware of the fact that they've got that, and
yeah, so an awareness of actually having the disease in the first place, but then also what it actually means for them, and then what they can actually do to manage the disease. Unfortunately, the education just isn't there at the moment, which is obviously what we're hoping to do with My Kidneys and Me. Hopefully that will get commissioned. That's the dream, that it'll get commissioned, and it'll be freely available for people, you know, when they get diagnosed, to have access to this information, which will then help them manage their condition.
Yeah. Great, thank you. And then I think we've got Reza. Reza Safari has got your hand up as well. Reza.
Hello. Thanks, Courtney, for the interesting and very useful study. I've just got one question about the, because you mentioned you've used the intervention mapping framework to design the online application. So how was your finding on the implementation side of this program? Because as you mentioned, you got another implementation study at the end, which is ongoing.
Yeah.
Have you got any finding in that stage, in that as part of that framework?
So I should have mentioned this when I mentioned about using the intervention mapping framework, that we only used the first 4 steps of the intervention mapping framework in the development of the program. We're then doing the 5th and 6th step as separate things. So the evaluation and the implementation are separate projects. So obviously we've developed the program, and then SMILE-K, which is our clinical trial, which is evaluating the program. And then we're going to do the implementation trial separately to find out whether we can get it embedded.
Okay, thank you. Just one more question.
That's okay.
On the funder, who was the funder? And what scheme did you apply for funding?
Funding in terms of?
I mean, the first stage of, as you mentioned, the first 2 stages before, up until the development of the online app.
So our team has a research program grant, and it's predominantly funded by a philanthropic donor.
Okay, yeah, thank you.
You're welcome.
Thank you very much, Reza. Thank you, Courtney. And if anyone else has any questions or any comments at all they want to raise? Okay, thank you very much, Courtney. That was really interesting to find out, and all the best. I hope that, as you say, the dream is realised and we get the resources that we need. Thank you. So thank you very much. And now I think I will move on to our final talk. So we actually have Ellen Hopwood, who's one of our PhD students, who's going to be speaking about self-management with multiple long-term conditions. So as I mentioned, Ellen is a PhD student here at the University of Leicester. Her background's in biomedical sciences. She's recently graduated with a master's in public health. She started her PhD here at the end of September 2021, supervised by Dr. Fionn Curtis, and her PhD is focused on self-management support for patients with multiple long-term conditions. So that's great. Thanks very much, Alan, and I'll hand over to you to share your screen, please. Thank you.
Thanks, Harini. Just share my screen. Can you see that?
Yes, we can. Thank you.
Okay, thanks, Harini. So as Harini said, my name is Ellen Hopwood and I'm a PhD student at the University of Leicester. This presentation is supported by my supervisors, Dr. Fionn Curtis and Dr. Michelle Hadji-Constantinou and Professor Kamlesh Kunti. My presentation today is going to be focused on self-management of multiple long-term conditions research. So the presentation will cover the following points. I'll give a brief background to multiple long-term conditions and self-management, some of which has already been covered by Harini and Courtney, but I'll kind of summarise it again. I'll also provide an overview of some of the current evidence on self-management of multiple long-term conditions. I'll also provide an overview of my research project, which includes its aims, anticipated impact and its objectives. I'll also provide an overview of NIHR's future priorities for multiple long-term condition research post-COVID-19. The NIHR definition of multiple long-term conditions is the coexistence of two or more long-term conditions in a single individual. This can include a chronic or physical condition such as cancer or cardiovascular disease, a mental health condition such as anxiety or depression, or an infectious disease such as HIV or hepatitis C. Multiple long-term conditions are associated with a reduced life expectancy, lower quality of life, and increased health service utilisation, which leads to great burden on both the individuals and also health services. Rates of multiple long-term conditions are expected to increase, with 2/3 of adults aged over 65 expected to have two or more conditions by 2035. And although multiple long-term conditions is often associated and thought to occur mainly in older populations, there is an increasing number of young people with long-term conditions, and particularly diseases related to obesity. Research surrounding multiple long-term conditions is also timely. Due to its strong association with severity of COVID-19 infection, with people with multiple long-term conditions at 2.6 times higher risk of COVID-19. In 2018, the Academy of Medical Sciences published an international policy report which evaluated the issue of multiple long-term conditions as a global health challenge. As shown previously, the number of people living with these conditions continues to increase, and meeting their needs is one of the biggest challenges facing the NHS. In 2018, it was reported that 1 in 4 adults in England had 2 or more health conditions, so that's about 40 million people. And the number of people with 4 or more conditions is expected to double by 2035. And also during COVID-19, that placed additional risks on those with multiple long-term conditions. A global survey evaluating the impact of COVID-19 on routine care for chronic disease found that most healthcare professionals identified moderate to severe effects on their patients due to the changes of the health services. Also, 80% reported that the mental health of their patients worsened during COVID-19. And with the healthcare and risk factor control being significantly compromised during the height of the pandemic, we will likely see an increase in multiple long-term conditions beyond those that were predicted in the 2018 report. So self-management is defined as the tasks individuals must perform to manage their conditions. And so this can include action plans, managing medication, goal setting, and emotional and behavioural management. Self-management support programs reduces the burden of these long-term diseases for individuals, and these can be led by healthcare professionals and also by other peers as well. These support programs can occur across primary and secondary care, in the community, and as Courtney has talked about, using digital platforms like My Kidneys and Me. These programs provide benefits to patients by allowing access to resources, which improves their knowledge of their conditions. It can promote behavioural changes, such as lifestyle or dietary changes, and may also provide opportunities for individuals to meet other people in similar circumstances. A recent systematic review focused on self-management interventions over a wide range of single diseases has shown them to be effective and has shown some positive improvements in self-efficacy and disease knowledge. The majority of studies included in this review were conducted in the USA and in the UK. However, this review noted that there was a lack of focus on multiple long-term conditions amongst this literature. it's been shown that an individual's ability to self-manage can be impacted by comorbid conditions. Cognitive impairments such as dementia are commonly co-occurring with other diseases such as diabetes, CKD and cardiovascular disease. And this can reduce significantly the ability for individuals to self-manage their conditions and receive support. A systematic review explored the interactions between mental and physical conditions, and it's shown to increase burden on patients and makes it more difficult for them to engage effectively with self-management and associated interventions. And the studies again included in this review were mainly performed in high-income countries. Two reviews from 2014 and 2015 focused on experiences of living with multiple long-term conditions. Tying in with the previous review, they noted that living with a mental and a physical condition can significantly impact a person's ability to self-manage. They used the example of pain and depression, as this can impact individuals' ability to self-manage by affecting their motivation and their ability to access services by travelling to those services. Other barriers included taking and organising multiple medications, receiving conflicting advice from healthcare professionals, and also the inability to access the services that they need. The additional barriers to the management of multiple long-term conditions has meant that there is a need for interventions which specifically target multiple long-term conditions, and they take a holistic person-centred approach to improve outcomes. An increasing number of interventions have been or are currently being developed at an organisational level and also an individual level, and some of them are focused on self-management, or they may include self-management components. So having given a brief overview of self-management and multiple long-term conditions, I'm going to talk about how my PhD fits in with the current evidence. So my PhD is currently entitled Self-Management Support in Patients with Multiple Long-Term Conditions in the Post-COVID-19 Era. I'm in my first year and I started at the end of September 2021, so it's still quite early stages. And my supervisors are Dr. Fionn Curtis, Dr. Michelle Hadji-Constantinou and Professor Kamlesh Kunti. And my PhD is funded by the NIHR Applied Research Collaboration East Midlands. So in terms of where my PhD fits in with the current evidence, I'm just going to highlight some of the evidence gaps. So most research on self-management has focused on single conditions with less focus on multiple long-term conditions, although this is beginning to change with more interventions and trials being performed. There's a lack of research and guidance regarding multiple long-term conditions in COVID-19 and how self-management burden has changed for patients over the course of the pandemic. NHS guidelines also tend to focus on single conditions and may not always account for multiple long-term conditions with the patient at the centre of the care. The overall aim of this PhD is to advance understanding of multiple long-term conditions and self-management support as we emerge from the COVID-19 pandemic. It's anticipated that this PhD will provide greater understanding of multimorbidity and self-management, particularly from a patient perspective post-COVID-19. And we also hope that this project will increase understanding and help mitigate against health inequalities for those with multiple long-term conditions. There's 4 objectives to this PhD project. I'm currently working on the first 2. My first objective is the systematic review to identify effective self-management interventions targeting multiple long-term conditions. This will be including both quantitative and qualitative studies. And we'll hopefully use this to inform the subsequent stages of the project. Objective 2 is the use of qualitative methods such as interviews and focus groups to explore healthcare professionals and patient experiences and perceptions of multiple long-term condition self-management. Objective 3 is the mapping of current referrals, provision and access to self-management support, and identify any inequities post-COVID-19. And the final objective is to develop a pilot study to explore a self-management intervention programme in patients with multiple long-term conditions. So currently we are working on objective 1, which is a systematic review. Just to quickly define a systematic review is a summary of all evidence, which is peer-reviewed studies, available on a specific topic, and these are collected across a variety of sources. They are conducted to answer predefined research questions and meet eligibility criteria with the intention of informing decisions and discussion. The stages of a systematic review are shown on the right-hand side, with the first stages being the development of the question and the development of a protocol, which details what you're planning on doing and your inclusion criteria. The next stage is the searching of databases and selection of studies, which will be included in the review. Extracting the required information from each of these studies is often performed alongside the risk of bias assessments, which assesses the quality of each study, such as how well were they designed and was the design suitable to answer the research question. The final stages include data analysis and interpretation of the results and drawing conclusions from the data. So specifically, my systematic review is titled Effectiveness of Person-Centered Self-Management Interventions on Adults with Multiple Long-Term Conditions, a Mixed Method Systematic Review. This review aims to answer 2 research questions. The first one is, are person-centered self-management interventions effective at improving outcomes in adults with multiple long-term conditions? And the second question is, what are the experiences of self-management interventions in adults with multiple long-term conditions, their relatives and carers, and healthcare professionals? We're hoping to use a mixed methods methodology to use a segregated approach to analyse the quantitative and qualitative studies separately. We'll use statistical analysis where appropriate to assess effectiveness of self-management interventions and use thematic synthesis of the qualitative studies to bring together common themes which explores the experiences, facilitators and barriers to self-management interventions. The intention is to find out whether and also which types of self-management interventions were effective using the quantitative studies and understand why they worked and the experiences of these interventions using the qualitative studies. This may highlight that although interventions may be effective, it may not be acceptable amongst participants as the experiences of the intervention were not favourable. We also hope that the review will help develop interview questions for the next objective by highlighting areas which may need to be explored further. So in terms of the progress so far with the review, previously when conducting systematic reviews, there have been issues when indexing studies related to multiple long-term conditions on databases. Mesh terms are used to help with this process, and these terms are official words or phrases which are selected to represent certain topics, and this helps index the articles on these databases. People who index these articles can only select the terms from this mesh list, so they can't use any of the spellings or variations of the phrases. And these mesh terms are very useful as they can be used to search databases as part of review search strategies to retrieve the relevant articles related to your subject area. However, multimorbidity has not always been an official mesh term, and this has made review searching difficult as other terms may have had to be used to index articles. And so there's difficulty differentiating between multimorbidity and comorbidity, as they do have slightly different definitions. Comorbidity tends to refer to the effects of other conditions in relation to a single index condition. However, in my case, multimorbidity has become a mesh term recently. I think it was about 2019. And so I could use it for this review, but I still had to use comorbidity as part of the search strategy due to other studies being indexed under using comorbidity instead of multimorbidity. So my search strategy included terms related to multiple long-term conditions and self-management, and I searched 5 databases and retrieved approximately 10,000 titles and abstracts. I'm now currently screening 330 full texts. And as I said before, I hope the findings of this review will inform the later objectives of my project. For the qualitative objective, I'm currently developing the protocol. The aim of this objective is to explore experiences and perceptions of multiple long-term conditions, self-management, and the impact of COVID-19 on these experiences of self-management amongst healthcare professionals and patients. We hope that this will identify areas of priority and outcomes which matter most to patients and healthcare professionals in terms of self-management and interventions. We also hope this objective will increase understanding of multiple long-term conditions and self-management support post-COVID-19. So I'm just going to give a brief overview of some of the future directions for multiple long-term condition research, which has been defined by the NIHR. So as the impact of a condition is influenced not only by health-related characteristics, but also by socioeconomic, cultural, and environmental factors, patient behaviour as well, all of which has changed in the face of the pandemic. Moving forward, future priorities for multiple long-term condition research in the post-pandemic era has been defined by the NIHR, and this is a key funder in this area. The NIHR highlights the need for holistic and patient-centred care. Firstly, we need to listen and identify the problems and outcomes that matter most to people with multiple conditions and their carers, and understand how they would like to see services configured to meet their needs. This will allow future research to be guided by patients and by what matters most to them. I'm hoping that the qualitative objective of my PhD will help achieve part of this aim. Another important area is to continue developing our understanding of which diseases commonly co-occur together, and this is known as clusters. Common clusters could offer insight into underlying causal biological mechanisms and disease pathways, and better understanding could inform risk management and the development of new drugs which may target areas of these pathways. This will help improve the management of multiple conditions and setting priorities in public health. As highlighted earlier, evidence on the best approaches to prevent multiple conditions is generally lacking, again in part because of our single disease focus. Supporting the design and delivery of interventions to prevent people from progressing from one long-term condition to developing more is a key area for improvement. However, improving quality of life for people with multiple conditions could also be difficult because solutions require actions beyond just healthcare, and there may be a need to target environmental, social, and economic factors. And finally, delivering research that enables the health and social care system to take a person-centred, whole-person approach to the treatment and care for people with multiple conditions, including quality of life and well-being. Intervention and drug studies have often excluded people with multiple long-term conditions, and this can leave uncertainty regarding how drugs or interventions work within this population. Future healthcare needs redesigned to look after people with multiple long-term conditions, with increased focus on guidelines for multiple diseases, particularly as rates of multiple long-term conditions are expected to increase further. Thank you all for listening to this presentation. I've attempted to give a broad overview of self-management and multiple long-term conditions, and then specifically talk about my PhD in this area. And I hope you've enjoyed all the talks today, and I'm happy to take any questions now, or if you would like to email me later in regards to anything, including my PhD. Thank you.
Thank you very much, Ellen. Thank you. Yeah, as Ellen says, please, if anyone's got any questions or comments, please feel free to post them in the chat or raise your hand. Okay, yeah, one of the things that struck me, Ellen, was that it's sort of so people who've got the interplay between complex comorbidities and treatment regimens actually tend to have lower self-engagement with self-management. Is that right? That was one of the things that that's been found.
So previously they've done some work on mental health and physical conditions, and they tend, particularly between mental health and physical conditions, tend to have a lower ability to self-manage due to the interactions between the two, and they kind of lead into the other. So it's the physical condition affects their mental health, and mental health affects their physical condition. So
that's the thing, and I think that perhaps they're the patient group that would benefit from engagement with self-management as well. And that's the thing, isn't it? It becomes such a tricky, vicious circle, and hopefully your research and your qualitative work especially will shed some light on that and kind of promote progress in this field. So we've got a comment from Sue Ballas, who says, I share your pain regarding conducting reviews. Can I ask which databases you're using?
Yes, so I'm using 5 databases. I've searched Medline, CINAHL, PsycInfo, Central, and Web of Science. Yeah, so a lot of databases.
So you said you've screened 10,000 titles and you've got 330 full text.
Yeah.
Gosh, I envy you. Gosh, yeah, well that's great work. I suppose that's reflective of kind of how just really the broad nature of the topic as well, isn't it? That it's as you say, that everything's been single disease focused, but not as much with multiple long-term conditions, and just sort of casting that net really wide. So we've got a question from Mark Gilbert saying, can you say a bit more about your ideas for a pilot intervention?
Well, at the moment, there's very few ideas. We're hoping that the systematic review and the qualitative objectives will inform kind of more of development, really. Kind of the objective 3 and 4 are still kind of in the preliminary stages of development. We're not entirely sure how that's going to take shape at the moment. So I can't really answer the question too well, because at the moment there's very few ideas.
They'll become clearer as time goes on.
Hopefully.
Your PhD. Yeah, absolutely. Okay. Yeah, and I think the other thing I was thinking as well was when you were talking about your review and searching, how actually there's been such a change in terminology, the terms that we use in what was multimorbidity, now multiple long-term conditions, and before that comorbidity, and sort of how that adds that layer of kind of difficulty when it comes to doing things like systematic reviews in this field, isn't it? How it's take those additional steps to make sure that you capture everything. So anyone else who's got any questions or comments, feel free to post them in the chat or raise your hand.
Can I just come back on that kind of point about the pilot, if I may? That's really helpful explanation of that. Can I talk to you about? So I've got loads of ideas kind of about it. I don't know kind of the appropriateness of trying to influence your kind of, but it's just by way of kind of ideas and suggestions. There's lots some work that we've been doing in East Kent on this. It'd be great to kind of run some ideas past you to see how that kind of might fit with some of what you're aiming to achieve.
I can put my email in the chat if that's okay. And then
I picked it up from the slides. I'll drop you an email.
Brilliant. That's great. Thank you.
Yeah, thanks, Helen. Yeah, you can. It's up to you whether you can pop it in the chat if you'd like to as well, and then
I will.
Slides around. Or if anyone wants to catch any of the presentations, again, there will be on the YouTube channel, on the ARC YouTube channel, the link for which will be in the chat later on, or on Twitter as well. So if you want to review any of the presentations there. So we've got a question from Sue saying, where are you hoping to publish your review, Ellen?
I'm not too sure, to be honest. I haven't really thought about it. I just want to get it done, to be honest.
Get through your full text review.
But I mean, if there's any ideas, that'd be great. But we haven't really discussed it yet. Sorry for not answering your question.
I think it is a big undertaking, isn't it? So that's the review where you're doing the mixed methodology. So you've got your quantitative element. So really you've got 2 separate reviews, haven't you?
Yeah.
So are you hoping to bring them together as well? So I know you mentioned you're going to do stats where you can and thematic.
Yeah, we're hoping to, once we've done the analysis of the quantitative and also the qualitative, to somehow to hopefully bring them together to see if they kind of correlate with each other. But we'll just have to see what the results are, because at the moment it looks like a lot of the quantitative studies are very heterogeneous. So it might be the statistical analysis might not be appropriate because of how different the studies are.
Absolutely, yeah. That's the thing. It's a common issue that comes up, I think, isn't it, in this field? And we've got, so Courtney had your hand up. Is that right, Courtney?
Yes, it is. Thanks for a great presentation, Ellen. I was just kind of curious about the prioritization of conditions. So how does, and then this might be something that you're exploring in the qualitative component, but how do individuals prioritize the condition to manage, and how do they deal with conflicting advice about different conditions?
Yeah, I mean, I don't really have the answers to those, but that's something that I think is definitely going to be explored in the qualitative. I mean, it might come through in the systematic review as well, but it's something that we're definitely hoping to explore with the qualitative in terms of how they prioritise conditions, because there could be a main condition that they concentrate mainly on, and then the other conditions kind of just get kind of put aside to fit with their kind of management programme.
Yeah. Okay, no, that's brilliant. I'm really interested in finding out what you learn about that.
Yeah, like I say, it's still really early stages, so there's a lot to kind of work towards and kind of work on. So
yeah, no, good luck. Sounds
you.
amazing.
Yeah, absolutely. I'm very interested, as I'm sure we all are as well. I mean, that's the thing, isn't it? It's an area that really needs looking into, and you know, as you say, it's sort of shed light on all these questions that, you know, that come up. Managing the complexity of multiple long-term conditions, I think it'd be really key. And we've got a comment from Gohar Ayman as well, saying, as a person living with multiple long-term conditions, I'm really encouraged by all the excellent work and much needed focus on multiple long-term conditions and the patient experience. Thank you. Thank you very much, Gohar. I'm very encouraged to hear that you feel that way as well. I think that's been the kind of overarching aim of all of our talks today, to promote patient experience and promote the patient-centeredness. Thank you. Okay, yeah. Any other questions at all, or any other comments anyone wanted to raise on Ellen's or any of the other presentations that we've had today? We've got a comment from Annie T. Akpan as well. Many thanks for all the exciting and encouraging presentations, and all data psychiatrists. Thank you very much, Annie T. Very, very glad you're able to join us. Thank you very much. Thanks everybody for coming along. So if there are no further questions or comments there, so yeah, Kieran's just posted the recording of the session on the chat function there, so you can review those at any time, or the first session that we held 2 weeks ago, that's also available on the YouTube channel. So I actually invite you to join us for the next session as well, in 2 weeks' time, on the 15th of June. So same time, starting at 12 p.m, and that'll be our last session, where we're sort of going to be thinking about real world evidence and future directions in multiple long-term conditions. Okay. Thank you very much, everybody. Thank you for your time. Thanks for coming along today. Thank you. I'll everybody carry on with your afternoons. Enjoy the bank holiday.